Thank you very much. We'll now move on to the last presenter of this section. Please proceed.
Thank you. Good afternoon. My name is Ayako Miyashita. I'm the HIV Law and Policy Fellow at the Williams Institute, located at UCLA School of Law. Thank you for having me here today. The Institute's dedicated to conducting rigorous, independent research and scholarship on sexual orientation and gender identity, both law and public policy. Many of our prior reports have identified disparities among LGBT communities across many aspects of life. Our focus today is on the particular health disparities faced by LGBT-identified individuals in California. So a few quick facts. Previous research has identified the following health disparities among LGBT communities in California. Heterosexual adults are more likely to have health insurance coverage than LGBT adults. LGBT adults are more likely to delay or not seek medical care. LGBT adults are more likely to have cancer. LGBT youth are more likely to be threatened or injured with a weapon in school and are more likely to be in physical fights that require medical treatment. LGBT adults are more likely to experience psychological distress, and LGBT youth are much more likely to attempt suicide. Men who have sex with men continue to make up the largest transmission category among people living with HIV, and even more importantly, bringing in what former presenters indicated, there's an intersectionality at work here. African American communities, particularly, continue to be disproportionately impacted by HIV, and so that overlap there among MSM and Black MSM is clearly identified. Historically, there's been a lack of standardized measures to collect sexual orientation, gender identity information in federal and state surveys. California, compared to many other states, is ahead of the curve. The information we do have about LGBT populations is available in large part to the inclusion of sexual orientation measures in CHIS, the California Health Interview Survey, since 2001. Other surveys that have included sexual orientation measures include California Behavioral Risk Factor Survey, also known as the California Adult Tobacco Survey, and California Youth Risk Behavior Survey. More recently, the Williams Institute has successfully worked to add measurements for gender identity to CHIS and has successfully fundraised to have this measure included in the next cycle. An additional measure for adolescents will also be included, asking about gender nonconformity. With the inclusion of the measurements, California will be the first state in the country to collect gender identity data in a population-based survey of its size. So what's missing? Well, collecting sexual orientation and gender identity, or SOGI data, the way we refer to it, is vital to understanding health disparities among LGB and particularly T populations. While we may have some data with regard to health and health outcomes, such as the information I shared with you before, what we do not have is data that describes the LGBT experience beyond that point. We remain unable to capture the LGBT experience with regard to service provision, and thus we're unable to assess the LGBT experience as it relates to accessing health care. And I believe Assemblymember David Chiu has introduced a bill this session to begin addressing this gap in data collection. And we just wanted to share today that based on our experience with both state and federal agencies in both making the case for data collection on SOGI measures and getting such measures included in large population-based surveys, we've found great success in creating and establishing ongoing collaboration with such agencies. And while you may be in the process here in California of identifying where inclusion of SOGI data measures makes most sense, we also urge you to think about the way in which survey questions could be made more appropriate for LGBT populations. For example, language referring to a husband or wife may be better presented as a question about a spouse. In this way, data collection can be done in a way that no longer alienates LGBT community members, and it does not make it difficult to respond to such questions. We look forward to seeing how California continues to be a leader in this regard.
Thank you very much. Is there any questions? Yes. Go ahead, Senator Manning.
Well, thank you, Mr. Chair and co-chairs for convening this important conversation. Unfortunately, as was mentioned by CPAN and others, these trends aren't new. Trends of health disparities. When we focus on disparities in health care, the suggestion is we're not providing sufficient medical attention. But as many of you have suggested, the disparities are not just in healthcare, the disparities are in health. And those are rooted, primarily the determinants, socioeconomic and racial. But within these divisions of access to care and quality of health, there's trajectories of disease and illness that are unprecedented in the last 5-10 years. Mr. Morales, you mentioned trends in diabetes in the Latino community. 1 in 2 Latinos are either pre-diabetic or type 2 preventable diabetes. What used to be referred to as adult onset diabetes is no longer called adult onset because we're seeing it in teenagers. So in your opinion, Mr. Morales or others, what are some of the determinants, and how do we compete in public health campaigns with $100 million marketing campaigns targeting these same at-risk communities? So I'm just wondering if you can focus on what you see some of the primary causes being. They're clearly multifactorial, they're environmental, they're nutritional, they're exercise related, they're insecure communities, violence, preventing children from feeling safe going outdoors. But one of our challenges is the marketing of products that are inherently unhealthful. And I'm just curious if in your work that is a focus of prevention and building healthy communities, not just treating diseased communities.
Right. Thank you for that question, Senator Monning. Diabetes is our largest priority at Latino Coalition for Healthy California. You know, if I were my bosses, I would fire me if I wasn't addressing it because it is so large. We cannot improve Latino health. We cannot move the needle on Latino health if we do not address diabetes. And yes, the roots of diabetes are complex. And, you know, we are working across the state with partners to reduce violence so people feel safe going outside and exercising in their communities, to increase the number of parks in their communities, increase access to fresh fruits and vegetables in the schools and also in food desert communities. But, you know, we're having a really hard time where we're really hitting a wall is when we start to address the issue, I'll just say it, sugary sweetened beverages. It's what we found, that's the unique driver. That's the source of the most calories of sugar for children. And, you know, we've seen that number of calories increase over the last 20 years. And so, you know, we need to do something. We need to get in front of this. We need to educate parents about what's going on. I know the senator has a warning label that I think that's a good step. It's a good effort to do that. But we also I think we need to get in front of this. This is an epidemic. This is something that's kind of snuck up on us. You know, when I meet with Latinos across the state, it's something that they feel is inevitable. It's become such a normal part of our existence that when I asked my aunt 2 weeks ago, do you have diabetes? Because my grandmother had it, my grandfather had it, my aunt died from complications of diabetes, and another uncle has it. And I asked my aunt, do you have diabetes? Her answer to me was, not yet. And it just rolled off her tongue. It wasn't even a thought process. It was just an anticipation of reality. So, you know, for us, we need to figure out a way to offset that $14 million of marketing that's being spent just in California to our children especially. So
thank you. And I think related to that, well, a recent survey released in my district, Monterey, Santa Cruz, San Benito counties, the public health officers of those 3 counties worked together in a survey of communities in the Tri-County area showing that children are drinking more sugar-sweetened beverages than water in all 3 counties. And if you talk about drivers of a public health epidemic, we look at the trends. 1 in 3 children will grow up in California today to have preventable diabetes. 1 in 2 out of minority communities. So it's affecting more profoundly minority communities, but it's affecting all of our communities. And the cost will be borne by everybody. So the disaggregation of data and the correlation of data helps inform us. When you look at our state budget and the billions of dollars that we're going to be asked to pay in complex medical management, that's going to be a cost borne by every Californian, regardless of their lifestyle habits or their health or whether they have prediabetes or diabetes. We all shoulder the cost. So there's an economic determinant here as well that is unsustainable. But more important than the economics is the quality of life. Children who don't have a choice, because it's not an informed choice, are being sentenced to adulthoods of complex medical treatment, amputations, lost productive capacity, and we have to break that out of these numbers as well. So again, I just want to thank all of you for the work you're doing with your respective communities and helping to inform us, but we can't let the complexity of the problem, the fact that it is multifactorial, stand in the way of us developing strategies for prevention and health promotion, which is the best way to eliminate disparities of health care.
Yes, sir.
So thank you, Mr. Chair.
Thank you. Anyone else like to have any questions? I don't know who's first.
Go ahead, go ahead. Go ahead.
I was just pointing that.
Oh, okay, all right.
Sorry.
I was trying to be respectful. Please, Assembly Member.
Thank you, Mr. Chair. And first of all, I want to thank you and this committee for holding this hearing on this very important topic. And just start by noting that about 10 years ago, the state of California, we had a discussion about whether we ought to collect data with regards to race and ethnicity. For those of you who remember Proposition 54, there were some in our state who did not think that it was important to know if African Americans got sickle cell anemia at higher rates than others, if Asian Americans got hepatitis B, or if, as Senator Manning pointed out, if Latino kids get diabetes. And knowing this information has saved lives. It has also allowed us to better target our scarce budget dollars and being smarter about how we move forward with things. I want to take a moment and reference, I know Mr. Tran talked about Assemblymember Bonta's AB 176 around disaggregating data regarding our API communities. Certainly I know Senator Nguyen and I represent two facets of a very diverse API set of communities, and it's incredibly important for us to know this data. I did want to ask a question specifically around LGBT data. I want to thank Ms. Miyashita for her presentation from the Williams Institute. You talked about the limited amount of data with regards to our LGBT communities, and I was wondering first if you could just share a little bit more. We have some data, but we know there's so much more data that we'd like to capture. If you could give some examples of the sorts of data that would be helpful to obtain. And then if you could just talk about what would be the positive benefits of having this data. As you alluded to, I have introduced and I'm authoring a bill that would hopefully move forward more increased collection of data regarding our diverse LGBT communities. This is incredibly important, not just to, again, address the health and other social service needs of our diverse communities, but to ensure that, again, we're using our budget dollars as wisely and as efficiently as we can. But if you could take a moment to talk a little bit more about, again, how would this data help?
Data that we have so far in California is really limited to sexual orientation. What that leaves out is gender identity. And the reason why asking questions about gender identity and should know that some of the best measures, aren't one question. So it can be a little bit more complicated. There are best practices to this, but asking about gender identity is incredibly important to figure out who amongst us identifies as being a transgender. So for those of you that kind of are used to having the term LGBT run off and roll off your tongue, even us at the Institute, we feel that way as well. We're very cautious about when we say LGBT because the reality is that the data on T, the transgender community, still remains fairly minimal. Having the ability to expand the G, the gender identity component of SOGI into a number of surveys has a lot of benefits. But number one is really just being able to capture who among us is identified as transgender. If California is able to add gender identity to its surveys, I mean, as I said earlier in my presentation, California will be the first state to be able to do so on a population-based survey. What that means is that we can make certain claims and we can look at that data and understand what's going on generally on a larger scale than just California. Now, there's some question about whether the findings of any California-based data could be representative of the nation, and I think that's still a question, but it would be the largest kind of population base from which we could gather that data. So it would help us to better understand the complexity and the diversity and the variation within the communities that we identify as LGBT.
Great, thank you. I just want to note two things. New York State has actually, at this moment, they are ahead of our state of California as far as the efforts that they have around data collection. So I am hopeful that our state will soon catch up. And then I wanted to just conclude by noting kids in LGBT families have poverty rates that are twice those of children in straight families. Hate crimes with regards to involving victims who were LGBT is the second most common type of hate crime, comprising of 25% of all hate crimes. And then certainly with regards to health disparities, the data that we do know shows that our LGBT families are at higher risk for cancer, mental illness, higher rates of smoking, and substance abuse, and that's what we know. And we also know that there's a lot we don't know. So again, I want to thank you for your work and hope to continue this conversation, colleagues, on this topic.
Senator Nguyen?
On that note, what I wanted to ask is, when you go forward data collecting, especially the LGBT community, one thing that I've seen, or at least in the areas that I represent, or in Orange County back then, is that depending on the community, it's very difficult to know if they are LGBT or not, because there is still a cultural that is not, I mean, it's very difficult for a lot of the communities, especially the minorities community, given mainly really for my community is really, well, in my district, the Vietnamese American community is very difficult to try to, for one person to come out and say, I'm proud of it, I want you to know. It's still not culturally acceptable. And so I just want to make sure that when we do go forward trying to collect these data, is that we do protect the confidentiality of it so that people want to give us that data, because ultimately for us as governments, we want to be helpful. We want to help, but having data, but lack of data because we didn't have enough pool also hurts us, because it becomes too specific and it only affects too small of a group that we need a larger number of volumes of individuals to collect that data from. And so, please make sure that whatever we do in terms of data collecting, and I know that there is a lot of confidentiality, especially in healthcare issues, but in anything else, is that, it is, the goal of data collecting is to make sure that we get enough data.
I believe Assemblymember, you had a follow-up comment or question?
Just a follow-up comment. Thank you, Mr. Chair. I just wanted to respond to the senator's questions. I think what many within, among policymakers who are interested in collecting more of this data with sensitivity to the issues that you've raised, the hope is that this data would be, first of all, collected voluntarily, so no one would be forced to provide information about their background, and then the data would be aggregated in such a way as to protect the privacy of individuals who provide that data. So those are two elements that are, I guess, part of the policy contours of how we think about this data collection.
Thank you. Anyone else have any comments, questions? Yes, Assemblymember Ridley Thomas?
Thank you, Mr. Chairman. It's a pleasure to join you all today. I came in a few moments late, but I'm interested in hearing about or discussing, and maybe with subsequent panels, about I think you all were talking about outcomes, and that's what I heard Senator Monty mention. But a part of the challenge that I'm interested in this dialogue, and appreciate our chairs for having this discussion, is about providers and how we make sure that we have workforce pathways for providers, how we create an environment of California that is inviting of a diverse array of providers, particularly in the chronically underinsured and communities, and those that are newly insured that have yet to build a sufficient health care IQ, personally and in community, to receive care. Again, forgive me if you've already spoken to it in one way or another, but if if anyone would like to talk about providers and a part of that challenge, because there's some things that have changed in consumption patterns and the like that clearly affect outcomes, and it's exacerbated when you already have inherent disparities. But in a medically underserved area, what about our providers? What about our pathways to for healthcare professionals? What about our training programs? What about gender and ethnic diversity in that conversation?
I can start with the conversation. One of our recommendations is absolutely that this information would also help agencies, plans, providers look at how do we make sure that our provider workforce meets the cultural and linguistic needs of our communities, that it is ultimately reflected in the population that they're serving. A couple of recent efforts have expanded. So data collection right now is done through the medical board on doctors and dentists. Recent legislation expanded that to some of the allied health professions like physicians assistants, psychiatric techs, and nurses as well. But again, more also needs to be done. There's not, again, a sort of systematic way of identifying, where the providers are, what the demographic breakdown is of providers. And I think having additional data would help us, but we also need to move forward efforts as well. There's a couple of other ways. The ACA provides for sort of additional funding to provide non-traditional healthcare providers like community health workers to bring those individuals more into the workforce, because these are also individuals who have a much more connection to communities of color and are able to meet some of those cultural and linguistic needs. And then also through the medical health homes is, again, expanding sort of the breadth of providers that can then provide various different aspects of care to individuals, and particularly among communities of color or populations that maybe haven't traditionally been served by the community.
Can I just add something as well? We also need to look at the barriers that might exist that keep some of our population from being able to access some of these jobs within the healthcare system. I know that we're part of the Alliance for Boys and Men of Color, and there was a bill that we were supporting last year. I'm having a birthday tomorrow, so I'm having senior moments now. I can't remember exactly the number. But what it was home care workers. People go through and they get trained to be a home care worker, but in the end they can't get licensed because of 10 seconds of bad misjudgment that happened 20 years ago. And that's a pathway that helps people. You start at the home health care assistant, then maybe you move up to nurse, registered nurse. Who knows where you end up, but there are barriers that still exist that we need to address like that as well.
I think one of the areas that Senator Monning touched on was the intersectionality of all the issues. I think an area that is particularly workforce development is the need for career technical education on a secondary education level to actually encourage students and young people to go into these healthcare professions. What we've seen in the API community is that there's not a lack of Chinese and Taiwanese doctors that are available here in California, right? The vast majority, or not vast majority, but there's significant populations. But you'll see in more rural communities like Fresno, Merced, Stanislaus County, in those areas, that's where you see the significant lack of individuals that are entering those types of professional trades. So career technical education on the secondary level to find those intersectionalities is important.
Last question, Mr. Chairman, with your indulgence.
I believe Senator Monning had a response, and we'll go to you, Senator Monning, for just a response, and we'll go to you.
Just on this issue that you raised on kind of workforce expansion, the chair's been a champion for trying to expand workforce linked to broader access in traditionally underserved communities. And I just wanted to mention along the line of your question, in our Budget Sub 3 committee hearing last week, the administration has included in the budget proposal that we're reviewing right now an increase in funding for the Song Brown resident primary care providers resident loan repayment. And the criteria for that is to incentivize medical students to pursue residencies in underserved communities. The data shows if you do your residency in an underserved community, you're more likely to stay and practice serving that same community. So it's, in my view, still an insufficient amount. There should be loan repayment for all students willing to serve in primary care and underserved communities, but at least it addresses that in this year's budget, expands it. So I think just to mention that, this is an informational hearing, but as our budget moves forward, I think that's a component worthy of support. Thank you, Mr. Chair.
Thank you. I believe Assemblymember Ridley Thomas had a comment, question?
Yeah, that's exactly right, Mr. Chairman. The other part that as community health advocates, I believe all of you are, is to help us and pay attention to yourselves, how we create an environment that is inviting for providers. Because if it's hard to do business in California, if it's hard to be engaged in the practice of care and the delivery of care, it will be harder to get underrepresented communities. It'll be more restrictive. So there'll be a number of topics that come up that are general business conversation topics, and then they get into healthcare, where it helps when you have already done the work and you've been in conversation with our offices about what it means to really get those pipelines going. I know about the Song Brown program, and we invested in it last year, and I'm glad that the governor has shown a commitment to investing in it further this year. And career technical education. He has a lot of money in for workforce anyway. I think it's unallocated increase in investments in workforce, which will benefit all of our districts, as will the four-year bachelor's programs. It's a healthcare program in my assembly district at West LA College. This is going to be a part of the pilot program for the four-year bachelor's out of community colleges. But just thinking about those general topics about operating a business and a business that's involved in healthcare, your input on that as we go along in the legislative and budgetary process will be extremely helpful. Thank you, Mr. Chairman.
Thank you. I believe Senator Pan had a question or comment.
Thank you, Senator Nunez. Actually, I wanted to follow up on Assemblymember Ridley Thomas's point, because I think it's a very important one. When we look at the workforce pipeline, right, there's the issue about the diversity of the applicants, the admissions, and it's right, I think as Senator Monning said, it is correct that people who do residency, but the caveat to that is they have to actually have a practice opportunity. And one of the challenges we have run into is that we've seen networks of physicians and other health providers, but particularly physicians who maybe, I've heard from African-American physicians, I've heard from API physicians, where they are trying to provide culturally specific services, but they're finding themselves boxed out of networks, right? Because they're actually taking care of a sicker population. They're taking care of us, our diverse populations that, unfortunately, if they're more disadvantaged, tend to be sicker, and they don't quite look as good as the quality measures. They may actually spend more resources because they actually have in-place interpreter, not interpreters, they actually speak the language, and so forth, and they have found themselves having some challenges getting into networks. I've heard this in LA, I've heard this in some other communities as well, and I think we just have to be sensitive to that, that when people, as we're trying to recruit people who are providing, services to healthcare services to different diverse populations, that they don't find themselves essentially boxed out. Because if you don't have a health plan, your Medi-Cal plan isn't when they contract with you, because their managed care plan decide they don't want to contract with you. It's going to be a little hard to keep your practice going, right? And that is an issue I have heard from some physicians and physician networks, particularly those that are serving diverse populations. And so I think we need to be aware of that and pay attention to that on the Medi-Cal side, and also Covered California and so forth.